Okay, so once we've ruled out all of our life-threatening causes, we're going back to our algorithm. Now we need to look at our non-life-threatening causes. So upper respiratory infection is usually referred to as the common cold and is considered a benign self-limiting syndrome. The common cold is the most frequent acute illness in the United States and the industrial world. And there are several viruses that we can associate with the common cold or upper respiratory infection. There's actually over 200 subtypes of viruses associated with the common cold. Rhinovirus and coronavirus is the most common, but adenovirus and enteroviruses are other viruses we associate most commonly with the common cold or upper respiratory infection. These do have seasonal patterns, so rhinovirus and parainfluenza tend to happen in fall and late spring. RSV and coronavirus are winter and spring, and enterovirus tends to be summer, where adenoviruses are usually not seasonal, but outbreaks may occur in military facilities, daycare centers, and hospital wards. So as we're talking about the common cold or upper respiratory infection, these symptoms are due to the immune response to the infection more than from the virus itself on the respiratory system. And the patient's usually going to present with the most common symptoms of rhinitis and respiratory signs and symptoms with this upper respiratory infection or common cold. Patients will have sore throat, cough, malaise. Fever is not common in adults but may be present in children. Both adults and children will present with conjunctivitis. The intensity of the common cold may be related to health factors such as age, underlying health illnesses, prior immunologic exposures, and the type of virus that's causing the symptoms. Most typical present symptoms is nasal obstruction, and scratchy throat and cough. And the cough may last past all the other symptoms. But what you're going to find is they don't usually have rales and lower respiratory tract involvement with their cough. Is usually not present in adults. Fever is usually low grade, but they are going to complain of pressure in their face and ears, like their ears and face, nasal area. They do have nasal discharge. It can be anywhere from clear to purulent, which is really good to note. Many patients and clinicians will place a lot of weight on color of discharge do I want to give antibiotics or not? We have to remember this is a normal process in the common cold, that it can run the gamut of purulent discharge. So you can't really use this to differentiate the color of the discharge to differentiate, is it sinusitis or is it a common cold? So that's where you really need to be asking questions about rhinitis. Nasal congestion is a must. So normally a patient with influenza is going to develop 1 to 4 days after their exposure to this. They're going to develop a fever, headache, malaise, and myalgia. Then after that, they get this non-productive cough, sore throat, and nasal discharge. If you've ever had influenza, you'll know, you feel like you've been hit by a brick truck when it comes on, and it hits you quick like that. So usually we know when this is hitting. Typically, influenza season is anywhere from October to April. Around here, it tends to be more that January to or December to April timeframe. But we'll see. So bronchitis. It's usually going to present with a cough with or without sputum production, which lasts for at least 5 days. And it is really self-limiting for the most part. It is going to resolve within 1 to 5 weeks. And its highest incidence is in late fall and winter when transmission of respiratory viruses peak. So, why? Because it's usually caused by respiratory viruses, and our most common viruses that causes it is influenza A and B, parainfluenza, coronavirus types 1 to 3, rhinovirus, and respiratory syncytial virus. But it is not unheard of. It can happen to have a few bacterial viruses that can cause it, meaning Bordetella pertussis, Mycoplasma pneumoniae, and Chlamydia pneumoniae. Just so you know, pertussis, the Bordetella pertussis, is the one bacterial that we do treat with antibiotics. So we do have, we do go after that one instantly with antibiotics, just so you know. Okay, so with bronchitis, their symptoms can include purulent sputum, also a cough, and here's the key. They may start with an upper respiratory infection for a few days and have that headache, nasal discharge, and sore throat, and then it goes into this acute bronchitis. And so what's going to happen is they're going to have those upper respiratory symptoms and then start to have some lower respiratory cough with it. And then what you're going to see is you might notice they have some wheezing and a little mild dyspnea. And so what's going to happen is when you're doing your exam, you're going to see the wheezing and an increase in rhonchi. But what's going to happen is when you do your exam and they cough, the rhonchi is going to clear. And that's going to be one indication that you're going to find that this could be bronchitis. You're going to start to suspect this, obviously, if it's lasted 5 days. Remember, they're going to have symptoms 1 to 3 weeks. And they may have some chest wall or substernal pain. But when you're starting to think of this is when you're thinking, no, they don't have all the pneumonia symptoms and they don't have chronic obstructive disease. You are not, usually you can make this diagnosis without a chest x-ray. You're only getting a chest x-ray if you're needing to rule out pneumonia and you're not certain, if you can't tell the difference between this and pneumonia. So when we're talking subacute cough, we're talking pertussis. And when we're talking pertussis, it's a bacterial infection with a relatively long incubation period, 7 to 10 days, but may be 3 weeks or longer. And we know this is typically a gram-negative rod, and is usually what causes this in most people. And the tissue involved is the respiratory epithelium, and It extends from the upper respiratory tract to the trachea, bronchi, and bronchioles, just so you know. What happens is, like I said, it has a long incubation period, 7 to 10 days, but it actually may have longer. It could be up to 3 weeks. There are 3 phases to this. It has the catahalar phase, the paroxysmal phase, and the convalescent phase. In the catahalar phase, it lasts 1 to 2 weeks. The patients are going to present with malaise, rhinorrhea, mild cough. Fever is uncommon, but they could have a low-grade fever. They are going to present with excessive lacrimation and conjunctival injection. Diagnostic tests are most accurate during this phase, and your gold standard is going to be a nasopharyngeal swab. And then we're going to go into our next phase. In our next phase, the paroxysmal phase, that's going to go into a series of vigorous coughs that occur during a single expiration. These vigorous inspiration causes a distinctive whooping sound, and a post-tussive syncope or emesis can also occur during this paroxysmal phase. And this is where we really get concerned. This usually will be worse at night with kids. It disturbs everybody's sleep, and it can be, very exaggerated. These coughs are very exaggerated. They could be precipitated by yawning, stretching, laughing, yelling, exercise, steam, mist. Other respiratory irritants such as eating, drinking can even trigger it. Patients often feel otherwise well and have few symptoms between coughing paroxysms. But when they are having them, they could be very severe. The younger the kid, they may not actually get the whoop, which if they're younger, the more severe this is, because those are the ones that you really have to worry about could go into respiratory arrest with the whooping, because they don't whoop. So what happens is we don't know they vomit, and then they aspirate and they go into respiratory failure. Like I said, this can last 2 to 3 weeks, and then they go into the convalescent phase. This is a gradual reduction in the frequency and severity of the cough, and then this can last 2 to 3 weeks, but may be prolonged up to 3 months. Clinical manifestations of pertussis in adolescents and adults are often less severe than in infants and children. So your chronic cough, your most common etiologies are going to be upper airway cough syndrome due to postnasal drip, asthma, or GERD. Other causes could be angiotensin-converting enzyme ACE inhibitors. Keep that in mind. Chronic bronchitis, bronchiectasis, neoplasm, foreign body, interstitial lung disease, and lung abscesses. Something else I'm going to mention here is don't forget to ask if they notice, and this doesn't go with upper airway cough syndrome, but this will help you rule out GERD. Don't forget to ask if they get that sour taste in their mouth. So, asthma is the second leading cause of persistent cough in adults and the most common cause in children. So you're going to want to think about asthma when your signs and symptoms include cough accompanied by episodic wheezing and dyspnea. Cough alone can be a variant of asthma. Common disorder in patients with atypia or a family history of asthma. Also, cough may be seasonal with asthma and may follow an upper respiratory tract infection or may worsen with exposure to cold, air, dry air, dust, mold, or certain fumes or fragrances. Cough also that follows initiation of a beta blocker therapy also suggests asthma. So keep that in mind.
Tests of airflow limitation are critical tools in the diagnosis of asthma. Spirometry, in which a maximal inhalation is followed by a rapid and forceful complete exhalation into a spirometer, includes measurements of forced expiratory volume in 1 second, or FEV1, and forced vital capacity, or FVC. These measurements provide information that is essential to the diagnosis of asthma. The purposes of a spirometry include to determine whether baseline airflow limitation or obstruction is present. This is usually manifested as a reduction in the FEV1-FVC ratio of less than 0.70. To assess the reversibility of the obstructive abnormality by repeating a spirometry after administration of a bronchodilator, usually albuterol, and also to characterize the severity of the airflow limitation based on the FEV1 as a percentage of the normal predicted value.
So when we're talking about asthma for patients with normal airflow, a normal FEV1, FVC ratio, identifying restrictive pattern as an alternative explanation for the dyspnea, the FVC less than 80 percentile predicted, we're going to do spirometry on them. And the severity of the airflow obstruction is categorized by the degree of the reduction of the FEV1 below normal. The severity of the airflow obstruction can be borderline, mild, moderate, and severe. The severity of the airflow obstruction in spirometry is not the same as the categories used by the National Asthma Education and Prevention Program guidelines to stage asthma severity, but this is what we do for some of these people. Bronchodilator's reversibility is tested by administering 2 to 4 puffs of a quick-acting bronchodilator, such as albuterol, with a spacer and repeating spirometry 10 to 15 minutes later. And you should see an increase in FEV1 of 12% or more, accompanied by an absolute increase of FEV1 at least 200 mLs, can be attributed to the bronchodilator responsiveness with a 95% certainty. The presence of a bronchodilator response in isolation is not sufficient to make the diagnosis of asthma. So with your asthmatics, you're also going to get a peak expiratory flow, or PEF, is measured during a brief, forceful exhalation using a simpler, inexpensive device, like you can see here. The PEF measurements are used to monitor patients with asthma, not to diagnose them. The spirometry is actually used to diagnose. You just need to have more than one. The PEF is used to monitor where they're at with their asthma. The PEF can be performed sitting or standing. Proper technique involves taking a maximal large breath in, putting the peak flow meter quickly in the mouth, sealing the lips around the mouthpiece, and blowing out as hard and fast as possible into the meter, like that. For a PEF, the effort does not need to be sustained beyond 1 to 2 seconds. 1 to 2 seconds. The maneuver is performed 3 times and the highest of the three measurements is recorded. That becomes their standard, and when we talked earlier, they don't want to drop 20 or 50% below that. So for gastroesophageal reflux disease, or GERD, your signs and symptoms are heartburn or sour taste in the mouth. These symptoms are absent in more than 40% of patients in whom cough is due to reflux. But I will tell you, your ENTs, if there's somebody with a cough, they aren't seeing other symptoms, they're going to throw them on a PPI to rule out GERD. I can tell you, I see it day in and day out. So if you've got a chronic cough and you're not seeing any other symptoms, don't rule this out quickly. Make sure you've got this in your repertoire of things to think about. Factors responsible for this cough are associated with gastroesophageal reflux. It can be stimulation of the receptors in the upper respiratory tract, the larynx, aspiration of gastric contents leading to stimulation of the receptors in the lower respiratory tract, and an esophageal tracheal bronchial cough reflux induced by the reflux of acid into the distal esophagus. As we have talked about our ACE inhibitor therapy, a non-productive cough secondary to accumulation of bradykinin, which is normally degraded in part by the ACE, begins within 1 week of instituting therapy, but the onset can be delayed up to 6 months. A tickling, scratchy, or itching sensation in the throat resolves within 1 to 4 days of discontinuing therapy, but can take up to 4 weeks. Reoccurs with re-challenge, more common in women and in those of Chinese ancestry. It does not occur more frequently in asthmatics than non-asthmatics. It is generally not accompanied by airflow obstruction. So with chronic bronchitis, it is defined as the presence of a cough and sputum production on most days over at least a 3-month period for more than 2 consecutive years in a patient without other explanations for cough. Almost all patients are smokers unless they are chronically exposed to fumes or dust. The sputum produced is usually clear or white, and a purulent appearance of sputum often suggests a concomitant upper or lower respiratory infection such as acute bronchitis, bronchiectasis, or sinusitis. Bronchiectasis is due to persistent airway inflammation that leads to progressive airway damage, and it's from persistent and severe damage. Bronchi become dilated and cystic, and secretions pool, and chronic infection from the lower respiratory tract. And it causes severe bronchial destruction. The main symptom is cough. They will have this muculent, purulent, chronic sputum all the time. Unless they're sick, then they get a purulent sputum. They have bilateral bronchi crackles and wheezing most of the time. The diagnostic gold standard is a chest CT with high resolution. So your lung cancer is going to be less than 2% of your cases of chronic cough, but it's due to neoplasms in the large central airways. But you want to think about it with a physical exam may reveal focal wheezing or diminished breath sounds indicative of focal airway obstruction from the tumor. Your bronchiogenic cancers may be considered in any current or former smoker So think about this with your smokers or former smokers. A new cough or recent change in a chronic smoker's cough. A cough that persists more than 1 month, especially somebody that's followed stopping smoking. If they quit smoking and they still are coughing after a month, you need to have a red flag up. If they have hemoptysis that does not occur in the setting of an airway infection, you need to have a red flag up. I'm going to throw out there also, if you get a smoker that all of a sudden has a drastic weight loss, start questioning if there's a cancer somewhere. I'm just throwing that out there too. Because when they've been a smoker or lived with a smoker, keep this in mind. And we are done.